This is now the distribution of access to treatment in children and 0 to 14. And you see here that South Asia has made the most progress when over 95% of children are accessing treatment. But I again want to point out the low coverage that we have in Western Central Africa, standing at 38% of kids accessing treatment. And if you look at the global figure, I talked about 54%. So West Africa is lower than what we see globally, and Eastern Southern Africa is at 57%. So lots of work to be done to reduce these disparities, find the children and link them into treatment. Next slide. Next slide. This slide just again looks at the two most impacted regions, Western Central Africa, Eastern Southern Africa, and you can see there our benchmark for 2020 again was 95% access, and you can see that none of the regions hit that benchmark. And when you look at the different countries in the two regions, only Eswatini has been able to reach 95% of its population of children with treatment. So lots of work, lots of gaps across countries for children. Next slide. This is a slide that talks about adolescents living with HIV, and our global estimate is that we have 1.7 million of them living with HIV, and 9 out of 10 of these live in sub-Saharan Africa. As you can see there, it's about 70% in Eastern and Southern Africa, and then we have 19% in Western Central Africa. I also want to point out that a lot of these children that are adolescents that are living with HIV are adolescent girls. Important to point out that a lot of these children that are living with HIV that are adolescents are transitioning from childhood to adolescence, having acquired infection from mother to child transmission. But we have also quite a significant number of children or adolescents that are acquiring infections during adolescence. And so the differential there of more girls than boys is illustrated on the next slide. Next slide, please. Next slide. So this slide just illustrates to you the disproportionate affection of girls compared to boys when it comes to neurons during adolescence. And you can see the global figure there that in this population of people, adolescent age group, 77% of new infections are in adolescent girls and young women globally. And you can see the distribution there where we have 87% in Eastern and Southern Africa being girls, and Western Central Africa following that. And you can see across three, other than East Asia and the Pacific, girls are disproportionately affected. And we really need to ask the question why, and that we know is the position of girls in society, not just from the economic, but also the cultural, the gender norms that we have increase vulnerability, girls as, you know, as they transition through this age group. And we know that most of these infections are starting to increase at around the age of 15. So what should we be doing collectively to protect our girls? Next slide. And when it comes to treatment, there's no gender disparity between boys and girls. And what we have here is similar to what we have for children, that 54% of adolescents are accessing treatment. And you can see that there's been a steady increase, but we're nowhere near the benchmark of 95% for this population. Next slide. And this is, again, goes through the country distribution in terms of access. And you can see that no country has hit the target that we set for 2020 of 95%. And there's variation across countries in terms of access. But I think the bottom line is that this is a population that's being left behind. And we really need to redouble our efforts to make sure that they have access. Using modalities that are relevant to them and using the tools that we have, including self-test, to make sure that we're reaching them with testing and then linking them to care. Next slide. And that's my last slide. And thank you very much. And just acknowledgement of the people that are behind a lot of this work: Mary Mahi at UNAIDS, Shafiq Saji at UNICEF, Mona at UNICEF, Chibwe Lam at UNICEF, and Savi at UNICEF. So thank you very much.
Thank you so much to Dr. Chewe for those detailed graphic interpretations of the data. The story that is told there is obviously one that is absolutely horrific. Those of us who've just joined in the last couple of minutes on Zoom, I want to welcome you, especially all my colleagues in the media. The kind of data and information and discussions we're about to have needs to be disseminated widely. It's critically important, and of course, mind share when it comes to the media, not least given our focus on the COVID-19 pandemic. So thanks so much for those journalists who are present with us both here and also this being a hybrid event in Zoom as well. I'm going to give you an opportunity in a few minutes to engage the public. We will honor those at the end of the formal proceedings. But what we're going to do now is to have a discussion or cobble together a discussion. We can't have it in person with all my panel members. And the idea is to drill down into that gap and question. And the first person I want to stay with actually is Dr. Chewe Luo that you've just heard from, that have given us the main presentation. And then after that, I will introduce our other panel members one by one as I ask each of them to respond to a particular question. Dr. Chewe, if you can hear me clearly, by the way, there was no echo, so just speak freely. We can hear you very clearly. How do we find the children and how do we make sure they have access to treatment? What is UNICEF doing?
Yes, and this is extremely important. I think we actually starting to focus on how do we become more precise in what we do. What we've been doing to date in the programs that we have is emphasizing the importance of early infant diagnosis. WHO recommends that at about 6 to 8 weeks, all children that are born to mothers that have HIV should access to a diagnostic test. We know that the demographics are changing in our children as we do better. You can see the coverage levels that I presented in pregnant women. So if we're going to be continuing to just look in places where we're implementing services for pregnant women to stop them from transmitting the infection, those places becoming extremely difficult in finding the children. So the type of children that we are missing are usually those children where mothers have no access to treatment, and so they're somewhere and we've missed them. But then there are also mothers that are continuing to breastfeed that might get infected, newly infected during the breastfeeding period. We also have mothers that are falling out of care. So again, the children are missing. So what we are saying is that we really need to understand the changing demographics. We need to have better use of data that we are collecting to have more precise, to have more precision in the programming approach. And so one of the things that we're really encouraging countries to do is to use what we're calling a family-centered approach. You talked about the number of adults that are accessing treatment, number of pregnant. We need to go back to those households of these adults that are within our care to make sure that every child in that household is actually tested. And we work with communities, civil society of people living with HIV, really to mobilize around HIV being a family disease, and that one infection of the family means we need to look harder to make sure that there are no people that we are missing in treatment, including children and adolescents. The second point that UNICEF is emphasizing, we call provider-initiated testing. We need to be looking very hard in those services where we know we're likely to find the children that are infected. And we know that sick child clinics, the yield in terms of HIV infection is very high. We know that pediatric units, children that are admitted for some illness, the yield is very high. We know that TB services, the yield is very high. Nutrition services, the yield is very high. So we're actually saying we need to be looking in those places, making sure we understand what proportion of children coming to these services have HIV, and then institute provider initiated testing. The people taking care of those children need to be sensitive to HIV and make sure that children have access, and then linking them into treatment. This third part of this is also making sure that we have quality services for children. So we have very good regimens now for kids, regimens that we haven't had for the long time, that are simple with minimal side effects, and dolutegravir comes to mind. We need to make sure that we are transitioning all children accessing treatment to these more effective regimens within in children within our care. Over. Thank you.
Thank you. That's really appreciated. 3 very succinct points. I'm going to introduce you next to Anurita Baines, who is the UNICEF representative to Lesotho, but of course has had many other roles that she has played, including regional advisor for HIV and AIDS at UNICEF Eastern and Southern Africa Regional Office as well, and all sorts of other leadership roles, including with the Global Fund, with UNAIDS and the Clinton Health Access Initiative also. And as I move over, Anurita, the question that I have for you to pause over is really, I mean, this isn't only about, of course, the stats over the last year or so and crisis during the pandemic. This is also about celebrating a really important milestone in terms of how long UNICEF has been on the ground. How did we get here, taking a longer view and celebrating what some of those milestones are that explain how it is that we got to where we are amid some of the urgent bad news that needs to be reversed. Today's event is also, in a sense, a celebration, isn't it?
It really is, and thank you for highlighting that. I think what's important to remember is while we do have the inequities and there's a lot more we need to do to end the AIDS epidemic among children and adolescents, we have made progress. And I think as UNICEF, we're really proud that we've been part of those key milestones over many decades. Let me name a couple. The first, my colleague Chewe mentioned elimination of mother-to-child transmission. UNICEF has really been there from the beginning, advocating to make sure that the science, the breakthroughs that we've seen in science, the improved treatment regimens are then applied to the programs and available at the health clinics to pregnant women living with HIV and for their children. And we saw in those graphs, you know, this incredible story of many countries in East and Southern Africa reaching 95% coverage to reach women living with HIV who are pregnant and to ensure that their children are not exposed and also living with HIV. I think the other is a really important area where UNICEF should take pride is bringing attention and focus to adolescents who are at risk of HIV and living with HIV. We saw the startling numbers from Chewe, particularly for adolescent girls who are at risk and living with HIV, especially in East and Southern Africa, where we carry the global burden. What UNICEF brought was really a laser-sharp lens to look at the data and really understand what was happening between the ages of 10 and 19, which we hadn't seen before. And lastly, and I think something that we're all proud of as colleagues in UNICEF, is really making sure children and adolescent voices are at the table, at the decision-making table, that they're part of the discussions when we're allocating resources, and that they have the ability and the agency to make changes in their own lives.
Before I go to our next panelists, just a quick follow-up question. One thing that struck me in one of the graphs that we saw is the incredible regional disparities, which is absolutely phenomenal. So not only do we have the gap to mind between children, adolescents, and adults, we also need to pay attention to those regions and particular countries that are underperforming in ensuring that we actually have global coverage for those who need access to treatment. What is the situation in Lesotho?
There's an old saying that we've used in HIV called "Know Your Epidemic," and I think it's so relevant today, and it speaks to what you've just said. You need to know your epidemic depending on what region you're in, what country you're in, what district you're in. So I'm in Lesotho, that's made tremendous progress in HIV. We have the second highest HIV prevalence in the world. It's a population of 2.2 million people, so the absolute numbers are small, but the prevalence is quite high, where 1 in 4 adults are living with HIV. But it's also a country that in the last 10-15 years has had this tremendous treatment scale up, and we're seeing more and more adults being tested, knowing their status, getting on antiretroviral treatment, and then pressed. Where we really need to continue to keep attention is around children and adolescents. First, preventing new infections among adolescent girls, but then also for the children and adolescents who need to be on treatment to make sure that they're taking their treatment, their medication every single day so that the virus can be suppressed. So it's a success story, but there are still some gaps, and we're not quite there yet, and we really need to focus in order to make that progress we want to see.
Absolutely. Well, the next person I want to introduce to you is a sociologist, Jaime Adorni, who is based in Chile, who is an expert in global health, public policy debate, as well as in sexual and reproductive health and rights related to those cluster of very important health regimes that all of us need to pay attention to. And the question that I have for you, Jaime, is to give us a sense really of what some of the challenges have been in terms of what young people have been facing in Chile, but Latin America more generally, particularly in the context of COVID-19. And I know when we chatted previously, there were 3 insights in particular that you wanted to share with today's event. So over to you.
Thank you for your question. There are certainly many challenges faced by young people living with HIV in Chile and Latin America. On the one hand, the COVID-19 pandemic has created more inequalities for young people living with HIV, as it has created more barriers and difficulties for them to access healthcare services, including access to their viral load exams and access to their medication. And some of the reasons why this happens include the overcrowded healthcare facilities, their own fear of getting infected with coronavirus, and in some cases, the unavailability of enough healthcare practitioners and medication. And this obviously leads to many young people being concerned and afraid about their health and well-being, as well as their undetectable status. However, there are also challenges and needs that have been amplified due to our current global health crisis, including many mental health problems and the inability to access strong support networks due to the effects of social distancing measures like mandatory confinements and mandatory quarantine. But also, many countries still struggle within the region to address mental health problems or social support networks as part of the services that are aimed at young people living with HIV. Likewise, there are still many challenges related and surrounding the experiences of stigma and discrimination faced by young people living with HIV in different settings, including healthcare services, but also schools. Many of these challenges can lead to serious problems like isolation and difficulties associated with the adherence to their treatment, which can ultimately affect their well-being and quality of life. And well, the pandemic has forced us to rethink strategies to help others, including our work with young people living with HIV. And we have continuously worked to expand our services and campaigns through online platforms, but also worked in better outreach projects to reach out to more diverse groups of young people. However, and faced by the continuous perils of the pandemic, as well as the new COVID-19 strains and variants, governments and countries within the regions should work to include the perspectives of young people living with HIV in their efforts to tackle the pandemic. Young people living with HIV should also be at the center of HIV policy development and policy work. So it's imperative to include them in all levels of policy development, and above all, to listen to young people living with HIV. Thank you very much.
Thank you, Jaime. That was crystal clear. Thanks for that. And it's really interesting how your remarks dovetail with what Anurita had said about the importance of young people being at the table. And it actually makes me feel bad because a good starting point is to critique ourselves. Because here we are speaking about the importance of them being at the table, and maybe they should be themselves instead of Eusebius saying that they ought to be here. This is a global event, and Latin America is one interesting focus. But we're going to move to a different part of the world, and it's going to be interesting to see whether the same themes around children not having a place around the table, stigmatization, access problems during COVID-19 also pop up perhaps when it comes to what is going on in Central and East Asia. And to that end, the next panelist that I want to introduce to you is Tahmina Kaidarova, who is an activist, and in particular, someone who is a defender and a promoter of the rights of women as well as adolescents living with HIV in Tajikistan. We're going to listen to her contribution And don't worry if you are not a multilinguist. I will translate for you what it is that she has to say in her native tongue. Tahmina, welcome to this event and share with us how things have gone for young people in particular living with HIV in Tajikistan and what you have had to do to change the way you work in order to continue supporting them.
Спасибо большое за ваши вопросы. Я очень рада присоединиться к мероприятию ЮНИСЕФ, посвященному Всемирному дню борьбы со СПИДом. Первое – это отсутствие психологической поддержки подросткам и их семьям по открытию статуса. В нашем регионе, в том числе в Таджикистане, не хватает психологов, врачей общей практики с знанием и навыком работы в этом направлении, которые могут предоставлять поддержку подросткам и молодым людям, живущим с ВИЧ, и их семьям. Из-за глубокого укоренившейся стигмы по отношению к людям, живущим с ВИЧ, детям статус ВИЧ часто не раскрывается вплоть до взрослого возраста. Ряд 2021 года при поддержке ЮНИСЕФ Таджикистан. Наша задача дать девочкам и мальчикам, подросткам, живущих с ВИЧ, которые помогут им принять ВИЧ-статус и реализовать потенциал. Они организуют консультацию, сессии с родителями, помогая им преодолеть страхи, связанные с раскрытием ВИЧ, стигма, дискриминация, гендерные аспекты и ВИЧ. Тем самым мы формируем правозащитное отношение общества к людям, живущих с ВИЧ. Тем самым мы создаем поддержку ментального и репродуктивного сексуального здоровья подростка и молодежи, что особенно важно в период пандемии COVID-19. Данные тематики стигматизированы со стороны общества, и подростки не получают психологическую поддержку от своих сверстников. Мы хотим, чтобы мир знал о важности данной работы, о важности предложения поддержки этим молодым людям.
Okay, thank you so much to that really fascinating input from Tahmina. I'm sure we can make available the English translation for media if you need it. So just chat to us afterwards and I'll get the team to make it available to you. But perhaps I can summarize just some of the key insights. And it's really interesting how there are certain, even though, as Anurita said, particularities, you've got to know your specific epidemic, how it plays out in your region. There are also some themes that recur in different parts of the world. Tahmina is with an organization called Teenagizer in Tajikistan. And perhaps there are three insights that I can share with you that come out of her remarks. The first is that there's a lack of psychological support for teenagers living with HIV. And the consequence of that is that it continues to be really hard to disclose your status. And in the absence of psychologists who are knowledgeable about HIV and AIDS, that lack of support means that many of the young people in Central Asia, in East Asia, if they do disclose at all, do so during adulthood. And of course, you can imagine the psychosocial difficulty and therefore the downsides in terms of their personal health that would have played out during many years of being an adolescent. So what this organization does is it attempts to intervene to try, in the absence of that psychological support, to help teenagers, adolescents to be able to live with HIV, including potentially disclosing and what that means in terms of how you go about dealing with stigma. One of the ways they do so, which is the second takeaway, which I think is really interesting, is also to work in particular, Anurita, with adolescents who are HIV negative, because we don't want them to become positive at the point at which you are counseling adolescents in Tajikistan who are HIV positive. You're already dealing with someone who's battling the world and of stigma and a lack of access to treatment. So part of the work that they do at Teenagizer is to specifically also work in a preventative way with HIV negative adolescents and also make sure that they understand that are living with HIV, which is another indirect way to make sure that stigma is reduced. And I think that's really interesting. And then the last thing is to advocate, and this is a topic on its own, perhaps we can come back to it in the Q&A if we have time or on another occasion, is that they also focus on opening up discussions around mental health as well as reproductive and sexual health, which is really important because very often we don't think about healthy sexuality in relation to adolescent HIV, and this organization does that. So those were some of the really important insights that came out from that particular contribution. I'm going to allow you as media to ask questions via Zoom or in the room if you are here, but I want to play two very short 2-minute videos before we do so. Again, we're going to go to another different region, to Indonesia, and I'm particularly keen on Asvian Hamza's video that I'm about to play for you. It's just 2 minutes or so, but here we have someone who's a young person himself, sociology student, 3rd year, but also getting training in counseling, and is in charge in part of a team dealing with a hotline as an HIV counselor in Indonesia. So we again get a sense of what exactly is happening on the ground in a different geography. Let's play that video.
Hello, greetings from Indonesia. I am very pleased to join the UNICEF media event virtually on the occasion of World AIDS Day. My name is Asvian, Interim Coordinator from Inti Muda Indonesia. Although the HIV response has made significant progress, young people, especially the young key population, are still facing several obstacles in multidimensional pressures such as their health status, poverty, patriarchy, and also ageism. Young people and adolescents remain at higher risk because of the policies and social, also cultural norms that prevent them from receiving comprehensive sexuality education. We are trying to fulfill the rights of young people, especially with the aspect of SRHR. For example, Inti Muda works with UN partners, the Positive Indonesia networks, and other community organizations to build meaningful networks in the community among young and adult people in what we call the Young Adult Partnership. In addition, we also strive to provide technical assistance to our member organizations in other provinces. In this program, we acknowledge that sometimes we feel that older people may have more power, so equality is fundamental. It is sometimes hard to convince adults to support the youth and take us seriously. Therefore, having the support of the government, UN partners, community organizations, and youth network will make us stronger. We are not only the key in making the change in the course of the epidemic. We are essential partners in the regional and global HIV response. Young population should be consulted and included as part of the solution at all times. Thank you.
Absolutely interesting. Thanks so much to Asvian. Another example of where support and resources are needed, that kind of lifeline, which it quite literally can be, is critically important. Someone else that I'm unable to see because of how the pandemic has messed up live in-person events is one of my favorite persons, and Gituko Shongwe, who's the UNAIDS director, the regional support team responsible for Eastern and Southern Africa. And of course, Anne is well known, who's got literally decades of experience when it comes to international development with various specialities. And I want us to listen to what Anne has to say. And then after that, we'll open it up for a conversation between the media and also my panel members, and in particular, Anurita, who's here with us.
The theme for this World AIDS Day 2021 is End Inequalities, End AIDS, End Pandemics. As we enter a 3rd year of the COVID-19 pandemic, we also enter the 5th decade of the AIDS pandemic. The AIDS pandemic did not take a break during COVID-19. In fact, people still died of AIDS. 4,200 adolescent girls and young women in Africa still got infected each week during COVID-19. Before COVID, we were off track to end AIDS by 2030. COVID-19 has pushed us back even further. The course corrections we need to end AIDS begin with a paradigm shift in global health financing, the financing that is required to address inequalities. We need to invest in community-led, in human rights-based, in gender transformative responses if we're going to end inequalities. The UN General Assembly's political declaration agreed on ambitious global AIDS targets for 2025. Meeting these targets requires governments focus on ending inequalities and investing in community-led responses and respecting human rights. Pandemics thrive on the fault line of inequalities. So human rights, gender rights, all the inequalities that persist within countries, between countries, are required to end AIDS and to stop future pandemics. Children, adolescent girls, key populations, including sex workers, men who have sex with men, transgender persons, migrants, prisoners, are amongst those most affected. In the end, we need to invest in our health systems to reduce inequalities and increase the economic growth and security for everyone, everywhere. Thank you.
Thank you so much to Anne, much appreciated. I'm now going to allow for questions. If you have a question that you want to ask, you can do so via Zoom or just indicate if you want to ask one. I will let my panel members handle the questions. And I'll ask just my team here in charge of technical to just monitor what's going on in terms of Zoom activity. And then we'll take those questions. In the meantime, Anarita, maybe I can start us off while we line up the questions. Anne says something really interesting there. From an overall systems analysis point of view, we really need everyone to be on board in order to make sure that populations at risk are the ones that are actually serviced so that their human rights can in fact be enjoyed, be affirmed. And as I'm listening to, I think to myself, the people with money and resources really need to in particular be held to account. And those are private interests, but also of course states are critically important because they've got a moral, legal, and a political duty to come to the party. Where are we at in terms of governments understanding the kind of data that we are disseminating here today and acting on it?
I think, it's interesting sitting here today, are mostly talking about another global health pandemic and trying to bring attention to the one that we've been working on for decades, HIV. And I think that speaks to the competing priorities in public health, the changing landscape, the global nature of public health pandemics. We've been advocating for years, not only for international resources. We've got the Global Fund, which provides resources and allocates money to countries to scale up the HIV/AIDS response, as well as the US government response, which is PEPFAR, but also a lot of effort to see increase in domestic financing for the HIV response. And I think what we're seeing more and more, and it's so apparent with the COVID pandemic, is that those investments aren't just for one disease. It's been about building the health system, building a resilient health system. And now we see how important that is, how the health system, particularly in East and Southern Africa, where I am, in order to not only progress on the HIV/AIDS response, but also to tackle new things that are thrown at us, like COVID-19. There are so many lessons, Eusebius, from the HIV response that can be applied to the COVID response. The way we've engaged communities, the way we heard today from colleagues in Latin America about mental health. We've been talking about psychosocial support in HIV for decades. That's basically mental health support. And we heard from our colleague in Tajikistan how important that is. Issues around disclosure. Thank goodness we haven't had the stigma around COVID in terms of letting people know that you've tested positive and isolating and quarantining and following public health guidance. A lot of those discussions around disclosure and having support from your family and community came from the HIV movement. So it's heartening to see what we've learned and to apply it. Qualities between Western countries and countries in this part of the world, in East and Southern Africa, and reminds us how we need to invest the resources, but also the focus so that we build the system.
Dr. Luo, I wanted to ask you a question that I'm almost scared might be a rhetorical one in terms of its horror, but let me ask it anyway. The disproportionate share of new infections among adolescents and children affecting girls rather than boys suggests statistically that obviously these new infections are not children born presumably with HIV, but who acquire it in infancy and as toddlers or as adolescents. What accounts for that? What is going on that explains, especially in sub-Saharan Africa, girls disproportionately affected when it comes to new infections compared to boys?
No, thank you. And I hope you can hear me. But I think this is information that we've had for a while. And we've been trying to unpack why. And I think it's an important question to ask. I just wanted to start by saying that when we look at across the life cycle, looking at adolescents from 10 to 19, we know that between 10 and 14, the infection rates in girls and boys is almost the same. And it's at around age 15 that we start to see the differentiation in girls. And we've been trying to figure out why. And I think we have come to some to Caprisa, that is based in Durban, and the group there under Professor Karim. They actually looked at this in South Africa, looking at it's called genotyping, to try and figure out for every infection that we see in an adolescent girls, where is it coming from? And a number of things were uncovered by that analysis. And one of the things that I'm sure in South Africa you've been talking about is just the issue of relationships and which populations girls are having relationships with. And I can say from that study that actually we found out that young girls, for what whether it's they're being coerced by the adult male population, that they're actually having relationships with much older men with a median age of about 8 years difference. And when you look at the dynamics of Africa, for example, and you ask yourself, where are the most infections when it comes to men? It's in that age band of men that girls are having relationships with that you have the highest prevalence in South Africa data in terms of who's accessing treatment among population. You also find that it's this same age bracket of men that are not accessing treatment as well as other parts of the population. So they're not virally suppressed, sort of practices where much older men want to have relationships with much younger women. Biologically, women are more vulnerable when it comes to economic determinants, gender stereotypes that we have that make the adolescent girl much more vulnerable. There are things that we can do. For example, we know that keeping a girl in school up to school completion is a good thing when it comes to HIV. It just doesn't empower them, but it also protects them from some of these practices. So I think there are elements of this that we understand. There are programs now that are launched, including in South Africa, that are multidimensional. And we're talking about layering these interventions so that it's not just about accessing testing, having antiretroviral therapy for prevention, that we look at the broader issues that we know girls are going through as we respond to their needs. Over.
That's really, really, really interesting. Jaime, I want to ask you a question. Let's see if it will not be lost in translation, I hope. But just listening very carefully to what Dr. Chewe has just said, what is the picture in Chile or in Latin America when it comes to girls versus boys in terms of how they experience their sexuality, what level of empowerment they have to be able to make safe and healthy choices? Or is there a massive disparity in terms of girls and boys and how they experience and negotiate adolescence? Okay, I think Jaime is frozen. We'll just see whether technology plays along with us, and we'll come back to him in a second. In the meantime, Arati, I wonder whether you can just also, for me, speak into this question of finding the girls. I mean, it's kind of bizarre, isn't it? Because when I think about girls that are lost to us, you think about, for example, the massive scandal in Nigeria a couple of years ago when you've had a bunch of schoolgirls quite literally just disappearing. But one of the key messages that come out of today's event for me is that we literally have got to find the girls, understand why they don't have access to treatment, and boys for that matter, and then make sure that we close that particular gap. From a country point of view, You've said that one can't be complacent in Lesotho, but to some extent it's a good news story. How does that gap, that is a 20 percentage point gap globally, how does it look regionally and at a country level when it comes to the country you're looking after?
What's so important is linking those girls to good quality treatment and care. And I think what we've learned in Lesotho is that when an adolescent girl comes to a facility or a health clinic, they may be coming for a specific kind of health service or interaction. It may be to test for HIV. It may be for a pregnancy test. It may be for some other information. It may be getting the HPV vaccine. And once you interact with that young woman, that girl, there's an opportunity to provide a whole range of services. So it's not that an adolescent girl comes and says, please just protect me from HIV. It's that I also need to stay in school. I also don't want to get pregnant. I want to be able to fulfill my own dreams and live my own life. We do see high levels of pregnancy among young women and adolescent girls in Lesotho. So we want to make sure that they have the quality services that they need, but then also they will have access to services for their newborn babies. So make sure that they're immunized, to make sure that they get some early childhood development support, some nutritional support. We've had work with the Ministry of Health that really is looking comprehensively at what a young woman or adolescent girl might need. And along the lines of exactly what you shared from our colleague in Tajikistan, it's the adolescent girls who are living with HIV, but it's also those who are HIV-free, so that they can learn from their peers and from one another and support each other. And we found that bringing them together, working with the Ministry of Health, working with nurses who are really on the front line. The way a nurse responds to a young woman or adolescent girl when they show up at the clinic is so critical. Working with the mother-in-law so that she has a daughter-in-law who also needs access to good health care, and making sure that we have this broader approach and that it's not just, seeing a young woman through the lens of a disease, but really thinking about what all her needs might be, including HIV care and treatment.
Absolutely. Yeah. Okay, we've got a couple of questions from YouTube. So before we move slowly towards the end of today's event, I want to take a couple of questions. And if you've got some, perhaps you want to put in the chat box, my team will have a look at those questions. So to my media colleagues, please ask questions. Not to fill my silence, I can speak forever and a day as a talk show host, but to make sure that we really accurately disseminate healthy data from a public health point of view and a health journalism point of view. But on YouTube, this event is also being streamed, and I've got a couple of questions. Maybe, Chewa, we can start with you. This question for you is as follows. In which countries would children and adolescents most affected, if we know, by the COVID disruptions? And do we understand, if we know, why those countries?
Yes, and so thank you for the question. This is data that we are following up from our global surveillance as we monitor the disruptions we're seeing in COVID. This is a collaborative effort between UNICEF, WHO, and UNAIDS, and we're looking into the countries. Sadly, we don't actually have country-specific data, but we do have sort of some understanding for us to be able to communicate what we are seeing across the board in terms of disruptions. It is very clear that because of the way we've put up our services for children, where mothers need to come in, and I talked about the 6 to 8 week time point that mothers have to bring their babies back for HIV testing, and we haven't done a good job with children to take testing out of facilities to be able to test children wherever they are, and we're working on that. We saw in the initial phase of the pandemic, the COVID-19 pandemic in 2020, in the first quarter of that realization of the pandemic and the fact that the responses within countries was lockdowns everywhere. And, there was so much fear on part of the population. The facilities also in terms of routine services were not up to the level that we wanted them to be because staff was being deployed to respond to this emergency. We saw in the initial part of the pandemic reductions in the number of testing that was going on in children, and because of that, we also saw declines of up to 50% in terms of treatment initiation. Fortunately, because of the communications that we've put in place, including making sure that we have SMS platforms that we use for appointment reminders to mothers, we were able to use some of these avenues to be able to reach out to mothers and populations around what was happening and where they could access services. We were also able to network the people themselves to make sure that they were talking to each other, to be supportive of each other, to make sure that they could actually do what they needed to do safely, including making sure that they had protective gear if they needed to, as they did the house to house, sort of reaching out to populations that they were aware of that needed this service. So we're able to see a rebound, both in testing and also HIV treatment within 3 months, but it wasn't up to the level we were before. And our concern is that, as I talked about the data, first of all, we're not anywhere near where we should be, the 95%, but we've also seen a stalling in terms of the increments that we're seeing annually. And we've been working with communities and populations living to make sure that they are supportive of each other and they can come up with real-time solutions within the countries where they are to be able to respond. And we're seeing this positive energy and response across countries. Over.
Thank you, Chair. That's really, really interesting. Anurita, the question also sparked some thoughts for you.
Absolutely. You know, Lesotho went to a very harsh and strict lockdown very early on in the COVID pandemic, much like South Africa. We saw immediate impact on uptake of services. So we saw a 50% decline in the number of people coming for HIV testing. We saw a 71% decline in uptake of medical male circumcision, which we know is an important part of the toolkit around HIV prevention. And then as Chewe has said, also a decline, 47% decline in initiation of antiretroviral treatment, so people who need to start treatment. I think that was a real wake-up call. We knew that there would be impact in terms of access to services. People were staying home and leaving only for essentials. So it was the harsh lockdown. It was also fear about what you might find at a health clinic when you got there and people being worried. But having that data, and I think that's something that UNICEF has done really well, tracking and understanding what the numbers look like, what the data say, and then using that to advocate and discuss with ministries of health so that we can change our approach and change the response. You know, in HIV, we've always done things like multi-month dispensation of treatment for people living with HIV. So that was very helpful. People had their antiretrovirals at home, but at some point it runs out. So it was to be able to track the data, understand it, and then have work closely with government to have a response.
Yeah, I've got a second last question, and then we will leave it there and get on to the final item of the main program. But in a sense, you've begun to answer the last question, also of you too, but I'm going to ask it anyway, in case you want to just add onto it. But the last response you gave us, Anurita, was the beginning of an answer. The person wanted to know what lessons from the HIV/AIDS response can be applied to the COVID-19 pandemic and vice versa. And I think it's really, really interesting, isn't it? I mean, we really struggle to get people to know their status and getting people to understand that it's safe and important to know your status. ARVs are important for enhancing and prolonging life and well-being. And now we're at a point where, you know, someone can be an ICU COVID-19 specialist nurse and sample to go and get a vaccine injected into their body.
Exactly. I think there have been a lot of lessons from HIV that we've applied to COVID and we need to keep learning from. One is around some of the practical ways of reaching communities, so the multi-month dispensation of treatment. Also using communities as part of the response. It was so important early on in COVID to hear from the head of state, to hear from ministers of health, but equally important for village health workers and people in communities to have the right messaging and be able to share that. In some of the peer support groups groups that we work with in Lesotho with young women, early on in the COVID pandemic, they were really scared about what is COVID, how does it spread, am I safe, and getting those messages to the people they trusted in their communities, not just relying on WhatsApp and social media, which often spread misinformation, but really getting that information important. And I think lastly in HIV, which we've done well, is to collect and understand the data and use that to inform the programs. We've had to do that in COVID as well. Now we see in the COVID response the way you can mobilize the global community to action, not enough in terms of vaccine access, but certainly in terms of attention and resources and understanding that we need to build the foundation of the health system and able to deal with these kinds of pandemics, I think will also help us in the HIV response.
I'm thoroughly enjoying this very important conversation, but we're going to have to bring it to a close soon to make sure we honor your time commitments for this event and that we can get on with the one-on-one schedule as well. Before we do so, we do have one final question for Tahmina, and we've got Ida with us in the room who's going to help with the translation, and then we will wrap it up after that.
Thank you so much. Госпожа Хайдар, у нас есть вопрос, обращенный к вам. И вопрос заключается, как ваша организация решает вопрос о раскрытии статуса ВИЧ-инфекции среди молодежи? And the question is, how do you address the question about disclosure of HIV status among the young people?
Благодарю за вопрос. Действительно, мы уже активно начали работать с 2021 года. Мы работаем, у нас имеется психолог, и мы сами ВИЧ-позитивные активисты, которые живем с открытым статусом, работаем с родителями и также подготавливаем подростков для открытия статуса. То есть, когда психолог видит, что ребенок 100% готов к раскрытию статуса, а родитель готов к раскрытию статуса, мы берем на себя по разрешению родителей, открываем статус ребенка. Если родитель сама готова к открытию статуса, мы также позволяем, чтобы родители открывали. Также третий момент, мы работаем с врачами, которые работают с подростками и детьми, и также обучаем их, как нужно правильно открыть статус ребенка, если у родителей страх, чтобы психолог открывал, или сами люди, живущие с ВИЧ, открывали, или родитель сама, перенаправляют к врачам, врачи сами как бы тоже с участием... Да, с участием психолога и врача открывается статус. Также сами подростки, живущие с ВИЧ, статус проводят группа взаимопомощи подростков. То есть они делятся о своем статусе, о том, что как они начали терапию, чем она помогает и какие результаты приводят. Вот такие работы у нас ведется. То есть параллельно они также работают, мы проводим тренинги для родителей по подготовке открытия статуса. На этих мероприятиях тоже участвуют наши подростки, которые уже знают о своем диагнозе. То есть они также делятся своим опытом с родителями.
Спасибо большое. And very briefly about the response from Ms. Haidar. Of course, starting from 2021, we are working very actively in terms of the disclosing status of the young people and adolescents living with HIV/AIDS. Of course, the main work is around kind of working with the young people themselves, building their capacity. Secondly, working with their parents, building their understanding, as well as working with the other psychologists who support them in terms of the providing and disclosing the status of young people. Also, we are working with the doctors who are providing support by building their capacity and ensuring that they are providing this работу. So and the last one is really working with the young people themselves who are sharing their experience on how to disclose their status among their peers.
Thank you so much. Well, that brings to a close the formal part of today's program. And I want to draw it to an end by just saying a couple of things. Firstly, I want to thank everyone who's been part of the program, who are part of the UNICEF family and who collectively have a deep and genuine and important interest in making sure that the human rights, particularly of vulnerable groups and populations like children, are affirmed and upheld around the world. And those panel members and speakers that have plugged in, whether it be from Indonesia, whether it be Tajikistan or Chile or in the USA or here in South Africa, thank you so much for being part of disseminating the latest statistics. The second thing I want to say by way of closing is also to thank my journalist peers. We often, and health journalism in particular, I think, isn't always appreciated as much as the skullduggery of political journalism, which is more my daily sort of part of where I hang out as a journalist. But from a public health point of view, disseminating this information is critically important. And I want to preemptively thank all of the media houses that have journalists present at this event for the reporting that you will be doing, including the interviews that we're about to have. And with that, last but by no means least, we're going to outro today's event with a video message from UNICEF's Executive Director, Henrietta Fore. Have a beautiful afternoon or rest of the day or early morning, wherever you are. And if you have a scheduled interview, make sure that you stay on and that you engage the communications team. And thank you so much for being a participant in this year's hybrid event. Business unusual, but that is the world that we live in. And the person that will have the last say is Henrietta.
Over the past 25 years, we have made great gains. 85% of pregnant women living with HIV globally are receiving antiretroviral therapy. A decade ago, it was less than half. Despite such advances, progress is uneven. If we are to end AIDS for children and adolescents, we still have much to do. In 2020, 850 children worldwide were newly infected with HIV every day, and 330 died due to AIDS. Although children represent just 5% of people living with HIV, they account for almost 15% of all HIV-related deaths. That reflects in part their low treatment rates. Only a little more than half of children with HIV receive treatment, compared to 3/4 of adults. The COVID-19 pandemic has slowed progress. It has widened existing gaps and created new inequalities in access to health services. This year, the UN Political Declaration is of greater importance for children and adolescents than any previous declaration in the history of AIDS response. Countries must now galvanize action, build on lessons learned, innovate, and realign programs to meet the ambitious targets agreed on in the declaration. On this World AIDS Day, let us recommit to provide better medicines, faster diagnostics, and smarter service delivery solutions. Let us confront inequalities for the most marginalized children and adolescents. And let us end AIDS once and for all. Thank you.